Hi, and welcome to ASTHOConnect, a national webinar on older adult falls featuring state examples, medical costs, and opioid misuse. My name is Talia Sands, and I am the Director of Health Improvement at the Association of State and Territorial Health Officials, also known as ASTHO. I am joined by the rest of the ASTHO team supporting our older adult falls prevention work: Dr. Marcus Plesha, Chief Medical Officer; Erin Bayer, Senior Director of Chronic Disease and Health Improvement; and Asyat Tukama, Senior Analyst of Chronic Disease Prevention. Today we also have the University of Vermont Medical Center team: Christina Keating, the Injury Prevention and Safe Kids Vermont Coordinator; Jennifer Gradden, Trauma Program Manager; and from the Massachusetts Department of Health, Rebecca Thomas, Director of Injury Prevention and Control; and Laura Coe, Technical Assistance Team Manager; and Carla from the Falls Prevention Coordinator position. We also have with us two panelists: Brenda Iliff, the Executive Director of the Hazelden Betty Ford Foundation in Florida, as well as Dr. Gwen Bergen, the Behavioral Scientist in the Division of Unintentional Injury Prevention at CDC. They will both provide expert perspectives on the state team presentations and tell us about the work they're doing in their respective space. The objectives of this webinar are to share Vermont and Massachusetts successes and challenges, as well as lessons learned in the Older Adult Falls Prevention Project, to discuss older adult falls intersection with opioid misuse, to discuss medical costs of fatal and non-fatal falls among older adults, and we'll follow this meeting agenda here. Today we will cover about ASTHO and the Quality Improvement Project, Massachusetts and Vermont team presentations, discussion with the panelists, ASTHO falls prevention resources, and we'll conclude with some final thoughts. So first, about ASTHO. ASTHO is a consensus-driven national nonprofit organization representing the state and territorial public health agencies in the U.S., U.S. territories, and freely associated states, and the District of Columbia. Here on your screen, you can see a map of our membership. ASTHO serves three core functions. We are a leadership home for state and territorial health officials and alumni. We are an advocate and voice for state and territorial health officials on Capitol Hill, educating and informing decision makers on issues that impact state public health. And we also provide capacity building to help state and territorial health officials and their program staff do their jobs better. We provide different forms of technical assistance, and the project you'll hear about today is part of our capacity building function. Over the last 3 years, ASTHO led a quality improvement project focused on preventing older adult falls and managing its outcomes. The project was embedded in ASTHO's framework for systems-focused quality improvement. Through the application of the model, we aim to achieve the following project outcomes: increased implementation of evidence-based public health programs, policies, and services, the establishment and maintenance of diverse public health partnerships for meaningful cooperation and achievement of evidence-based public health strategies and interventions, and utilization of the ASTHO systems change framework, stakeholders, and process to support a quality improvement process focused on falls prevention. For the first 2 years, we worked with the Vermont Department of Public Health and their partner communities, and this last year we worked with the Massachusetts Department of Public Health and the University of Vermont Medical Center. In working with these state teams and their partners, we utilized the Plan, Do, Study, Act cycles, also known as PDSA cycles. This involved developing an aim statement, establishing outcome measures, using evidence-based practices and tools to identify strategies, conducting rapid cycle tests of change. Now that you have heard the background on the project, we are going to turn it over to the state, and we will begin by hearing from Christina, also known as Chrissy, from the University of Vermont Medical Center. We'll then hear from the Massachusetts Department of Public Health, from Laura Coe. They'll each describe the burden of falls in their state, provide an overview of the activities they conducted throughout the project, and then share their outcomes, key successes, and lessons learned throughout the project. So Chrissy, I will turn it over to you.
All right. Thank you so much, Talia. We're very happy to be on this webinar today. I am representing the trauma program at University of Vermont Medical Center, and I will be talking to you about our falls prevention pilot project. There were several of us on this team, but it's myself, Christine Dillon, who is also injury prevention coordinator, and then Jennifer Gratton, who is our trauma program manager. So a little bit about University of Vermont Medical Center to give you some background information. So we are a nonprofit organization, and we are part of a 6-hospital network serving patients and families in Vermont and northern New York. And we are the only level 1 trauma center in the entire state of Vermont, small but mighty state. And we are a level 2 pediatric trauma center. We have about 562 licensed beds. So as Talia mentioned, we use the PDSA model to develop our pilot project and to identify key stakeholders and collect data. And it's no surprise to anyone that falls is a big problem for most of us. And you can see that unintentional falls comprise the largest portion of the burden of injury in Vermont. And in 2014, there were 137 deaths in Vermont due to falls, and there were over 20,000 emergency department visits. And what we found, we do have a lot of interventions in the state, but what we found was that there was a lack of falls prevention community resource options offered upon discharge for patients with a falls-related injury. So that was an area that we thought we could dive into a little bit more in the hospital. So patients were always advised to follow up with their primary care physician, their in-home care provider, or they were referred to the UVM Medical Center Falls Clinic upon discharge. But if for some reason they didn't follow up or they didn't have an in-home care provider, many of them became patients again because of a subsequent fall. And we just thought maybe they didn't know what community resources were available. So here are some stats for our trauma admissions in 2017. On the left-hand side, you see all the various mechanisms of injury, but you'll notice that 41% of the total admissions were falls-related. And this is some more information. This is the graph on the left is the falls by age and then the mechanism of injury. So as you can see, the population, from 70 and older comprised the majority of the falls, but we found that the less than 15 area was another perspective that we could look at in the future. And most of these falls were in the home. So for our pilot project, our aim statement was to educate the at-risk inpatient population on falls prevention interventions in their community and hopefully, in turn, reduce the number of falls-related readmissions to UVM Medical Center. And the strategy that we took is, first of all, we organized a stakeholder working group that we met on a monthly basis, so that we could figure out, what our aim statement was going to be, and then how we wanted to address that aim statement. So after lots of meetings, we decided to create a falls prevention education booklet. And then we wanted to identify an inpatient medical unit to distribute this booklet. And then, of course, to track the patient data. So here's a list of some of our stakeholders. As you can imagine, we had a hard time getting all of these very important people to the table, but we did get really great buy-in from senior leadership and the managers of all these different programs. And I would say that acute care PT and OT, and then outpatient PT and OT and case management were critical stakeholders in the process, as well as the nurse managers and the staff on the medicine unit. So we found this booklet, or excuse me, didn't find the booklet. We found this folder that you can see there. It's My Healthcare and Discharge, that was created by one of our units in the hospital for their patients. And we caught wind of that, and we thought, what a great resource this is in order for our patients to keep all of their information organized upon discharge. And so we thought that that might be a really great opportunity to recreate our own folder that's very similar to the original, but then we wanted to add our packet to the folder. So as you can see on the right-hand side, that's a picture of the cover of the booklet. And one thing that we talked about in our group is that once you start talking about falls and using the term, falls-related injuries or a falls risk, a lot of people stop listening because they don't think that it applies to them, or they just don't want to admit that there are falls risks. So there is a movement to not use the term falls and use terms like staying steady on your feet. So that's why you see that on the cover of the booklet. So part of the rollout for this initiative was to educate the nurses on the medicine unit. And I created this document that gives some background history on falls and falls in the state of Vermont. It also highlighted our goal, which was our AIM statement, and then what the nurse's role was in the project. And then we tried to outline the order of events. So how do they give this information to the patient? And then what the next steps were going to be. So I was going to provide additional information and training at various shift changes. So the role of the nurses was to give every patient to that particular medicine unit a falls prevention packet as part of their patient welcome folder. And then they were to document that in Epic to indicate that the patient received the falls prevention packet. We tried to make this as easy as possible and as streamlined as possible, because the nursing staff has a lot of initiatives that they were going through at the time, as well as we are in the middle of a large Epic update. So we were trying to make it as easy as possible for them. So this is what it looked like in our system, where they documented the packet was in the arrivals section under discharge planning, other services, and then there was a line in there that says other, and that's where they were to put a key phrase, stay steady, so that we could then track how many patients were given the document. So we rolled the pilot project out in September of 2017. All the unit nursing staff were trained. I offered up 3 training sessions, trying to hit them in the morning and in the evening shifts when those shift changes happened. To thank them for taking on this pilot project, we tried to provide lots of incentives. So we sent up coffee and food and other drinks that we offered up at each training. And the nurse manager emailed all the staff the how-to guide that you saw in the previous slides. The official start date was September 11th of 2017. And what I asked of the staff was to send me feedback, what's working, what's not working, how's it going, and I try to follow up with that, with the floor as much as possible. The nurse educator on the floor would email me when they needed more packets, and I would go up on a regular basis to check in with them and see how the pilot project was going. Also, each month after the rollout, at the end of the month, I did a report in Epic to see how many packets were given out and how it was being documented. So approximately 450 Stay Steady on Your Feet packets were distributed between September and January of 2018. And admissions for Baird 4, which is the medicine unit, in the same time frame, there were about 787 admissions. So we think about 57% of patients received the packet. So better than nothing at all. We didn't get 100% compliance, but we feel like over half was a good start. And what we did note was that patients readmitted for falls were not on our Stay Steady report. So that indicated that they did not receive a packet. And readmission for falls within 6 months, they remain stable, and they're about 1% of our total readmissions. So lessons learned. It was very difficult to get all the stakeholders together for the meetings. So you have a lot of very busy people from various departments. And even though there was great buy-in, sometimes it was hard to get everyone at the table at the same time and communicate the message to everyone. Also, conflicting demands and initiatives on nursing staff, what made it difficult for them to complete the pilot project. And if you note in the previous slide, the pilot project went from September to January, and I noticed that there was a significant drop-off in patient packets being given, and I went up to talk to the nurse manager, and there was some misinformation out there about the pilot project being complete, and between that and the Epic rollout, there was a lot of, the nursing staff was being pulled in a lot of different directions, so it was very difficult for them to complete the pilot project. I checked in, like I said, on a regular basis and had meetings with the nurse manager, and there were many different avenues that we took and many different tweaks to the process and to the pilot project as we went along in those couple of months, just to make it a little bit more streamlined and a little bit easier for the nursing staff to follow through with the pilot project. And we made changes as needed. And being flexible is one of the more important things. It is a pilot project. There will be successes, there will be failures, and as long as you're learning from them and making necessary adjustments, we feel like we're moving in the right direction. But the one thing that we did want to drive home was consistent messaging around falls, and we used the CDC Stay Steady website as our guide. So next steps, we are still in the middle of the Epic software update. So that's a big, I'm sure many of you are going through this as well or have gone through it. It takes a lot of time. So we know that it has affected the data that we're seeing and the documentation. So we decided to put that pilot project on hold for that particular unit until the software update is complete. And we still we continue to support the Falls Free Vermont Coalition initiatives. We have a wonderful coalition here of various partners related to falls prevention, and we meet on a regular basis, and so we continue to support those efforts. And then we continue to collaborate and support any effort from Vermont Department of Health. And that includes updating the Falls Free Vermont website to make it more user-friendly. So the Falls Free Vermont website, if you want to go to it, it's, I believe, fallsfreevermont.org. And it has a lot of the community resources in there that people can access in addition to Falls information. And the exciting news is that the hospital's NPG, which is the Patient and Family Experience Global Council, they also caught wind of the folder that we used for the pilot project, and they are going to be rolling that out hospital-wide. So every patient will be getting one of those folders to take home that will house all of their patient discharge information. And we are going to be meeting with the NPG group next month and talking to them about putting our falls prevention Stay Steady packet in each of those packets as well, in each of those folders. So here is our contact information. If you have any questions about the packet or the booklet, if you would like to get a copy of it, I'm happy to send that to you. Or if you just have questions about our falls prevention initiatives in the state of Vermont, I'm happy to help. Thank you so much.
Thank you so much. Thank you so much, Chrissy, for your excellent presentation and for all the work you've been doing. It's really exciting to hear what next steps you have lined up, and we've been flagging a couple questions that have come through the chat box for our Q&A discussion a bit later. But we'll transition now to hearing from the Massachusetts team. So I will turn it over to Laura Coe to introduce herself and her team and present on her work. Laura, over to you.
Great. Thank you so much, Talia, and to ASTHO for setting up this webinar. And great job, Chrissy. It's exciting to hear about your work in Vermont. And I'm excited to be able to talk to you today about the work that we've been doing in Massachusetts around falls prevention. So let me just fix my slides. It's unfortunate we couldn't join by video. I think it's nice to see a face, so there's my face. And I wanted to spend a little bit of time talking to you today about some falls prevention work that we started through the Clinical Community Partnerships for Prevention program that was able to be carried on through ASTHO funding. So I'll give you a little bit of background on that program as well. So here's my outline. Talk a little bit about the burden of falls in Massachusetts, but I'm sure people are familiar with that, the burden of falls as a public health challenge that we face. And then, as I said, an overview of the Clinical Community Partnership for Prevention program that we've been implementing for the last 4 years here in Massachusetts. And then details about our ASTHO project that we just completed recently and recommendations. So again, I think people are familiar with the general concepts here about the burden of falls, but here's some specific data that a team member of mine pulled for me, Carlos Acercha, who's on this call, and I should recognize Rebecca Thomas is also on the call from our team here at in Massachusetts. So it's a significant issue in the U.S., and Massachusetts is no different. It's the leading cause of unintentional injury, hospitalizations, and deaths. So there's some data here showing the scope of the problem. It's costly. It's devastating for our citizens and has significant impact on disability, dependence, and depression. So the good news is, as we know, most falls are preventable. So we have lots of resources, including the STEADY resources that Chrissy was mentioning on the CDC website that are phenomenal, that are geared towards, there's tools geared towards providers as well as patients, as well as caregivers. So I highly recommend, if people aren't familiar with those, to to check those out. And then there's so many wonderful evidence-based community prevention programs that really impact the fear of falling as well as falls. So they're listed here: Matter of Balance, Tai Chi. We, as part of our program, implemented a home safety assessment that was led by CHWs versus the more classic OT home safety eval. And there's many others than what are listed here. So we have all these great programs. They're evidence-based. They impact falls risk and falls, yet they are not always referred to by clinicians and often have limited reach in terms of how many people in the community are aware of them, have access to them. So, unfortunately, we've found that PCPs largely are unaware of these programs, or if they're aware of them, don't know how to facilitate getting their patient to one of these programs. A study here in Massachusetts that Jonathan Howland from Boston University Injury Prevention did recently, and we presented at our last in-person meeting, showed that of 97 primary care physicians in Massachusetts, only 14% of them are aware of STEADY, and most aren't familiar with programs. So I think there's a lot of opportunity there to work with PCPs and healthcare providers in general. As Chrissy was talking about in the hospital environment, we've done a lot with primary care, and I can share some of those results with you. So this is just a one-slide overview of what our clinical community partnerships for prevention did. So we funded 9 partnerships throughout the state that included clinical sites, mostly community health centers, as well as community-based organizations. And they worked together to refer patients at risk for multiple chronic diseases to evidence-based community interventions, such as Matter of Balance, Tai Chi. So we focused on multiple chronic diseases, and they're listed here: pediatric asthma, tobacco, hypertension, and older adult falls as one of the 4 priority conditions. There was significant funding dedicated to this project through the state. It was $57 million for the 4 years, and it was part of legislation that was looking at cost containment, which was our sort of second phase of healthcare reform here in Massachusetts. So it was an exciting program, really unprecedented investment in prevention, and the goals were really to show improved health outcomes as well as cost containment for these key high-burden, high-cost chronic diseases that were impacting our state. So this is probably more information than I need to share with you all, but there were eight of the 9 selected to work on falls prevention specifically, which captures 50 organizations, 23 clinical sites, over 34,000 patients over 65, and 27 community sites representing over 135,000 clients. And these are the organizations, the regions listed here, if you're familiar with any of these areas, but they crossed the state. They represented urban, rural, and suburban areas. So this slide just depicts our model showing Linkage as the innovation here that we were really focused on in the middle. So the left side shows on the clinical side, the interventions were really targeting screening, treatment, and referral. And then on the right-hand side, we see the community interventions were really focused on engaging patients, enrolling them, and completing them. And then in the middle was this linkage that we funded intentionally at very high levels and invested in different methodologies for linking patients. So we had an electronic linkage program that was embedded in the EMR that went to an email-based system at the community side. And we required a feedback report so that the communication was bi-directional. So some of our results. This is a busy slide, and I apologize, but this shows, just honing in on falls, our 3 main interventions, which was the CHW-led home visit, the first 3 bars, Matter of Balance is the second 3 bars, and Tai Chi, the last 3 bars. And these show, the blue here is the clinical referrals, so when a primary care provider referred directly to a community site, how many patients. So this is a 3-year time period showing referral, enrollment, and completion in these different interventions. So you can see there's generally a drop-off from referral to how many enrolled and how many completed these interventions. But overall, we over 7,600 patients were referred, 8,700 were enrolled, and 4,000 completed all of these falls prevention interventions. So this slide is sort of an overview of some of the results of an evaluation that was done on our program. These data aren't current in that this was completed, the evaluation was completed in March of 2017. So we've been collecting data ongoing, and we have updated data here that I'll share with you, but this is what has been published in the evaluation that was done by an independent evaluator. So based on modeling from expected rates of falls and injuries based on BRFIS data, the Prevention and Wellness Trust showed in a 2.5-year time frame a reduction of 1,800 falls would be prevented, 110 medical emergencies, so that includes medical care and some hospitalizations for falls, with a total cost of $362,000 of costs averted in this 2.5-year time frame that was evaluated. And then the 4,500 individuals is just data based on our interventions that I was just showing you over time. And then I just wanted to share, because we have updated numbers for these statistics, and given that we have additional year of data, the falls prevention number is over 2,400, and we have approximately 600 fall-related injuries, 130 medical care, and 20 hospitalizations would be prevented with a cost savings of over $500,000. So I apologize that I didn't have that data updated for you for this slide. Also, we've seen a significant increase in screening for falls by primary care. So we trained over 250 primary care teams using STEADY tools for screening, treatment, and screening including assessment, treatment, and referral. So we're very proud of that because it was a huge systems change undertaking. Routinely, these community health centers were not screening for falls risk. In addition, we've trained hundreds of staff on the community interventions. So we've trained leaders and trained the trainers and master trainers in many of these evidence-based interventions that now can be offered in a sustainable way. This is just a quick snapshot of our STEADY screening, as I was talking about with our primary care sites. So this only represents 1/4 of data, but it gives you a sense of our screening rate. So for this 1/4, 41% of patients over 65 were screened. 30% had a gait strength and balance assessment completed, and 51% who screened positive had a multifactorial assessment and plan of care. And this is all per STEADY guidelines, recommendations that are evidence-based guidelines recommended. And 4% were referred to CBOs, community-based organizations. So that's grown significantly, but this was just a snapshot of our STEADY data. So we're proud of this result in that, as I said, this was close to 0 when we started. So now I'll switch gears and talk specifically about our ASTHO program, our ASTHO project, and we're grateful to ASTHO for funding us to continue looking at falls prevention. So we focused on community-based screening events And our partnerships were really eager to screen in the community. Our program had really focused on screening happening in the primary care sites, but many of our community-based organizations were interested in screening, know their clientele, know that people are at risk, and we're excited to have a process to do screening and then refer them to these interventions as well as back to their primary care. So we had 3 participants, the Berkshire, Quincy, Weymouth, and Metro West partnership teams participated. We had a short time frame for doing this project, but we were impressed with what was accomplished in that window, and each of the partnerships received $7,000. Here's the goals for our Learning Collaborative. So to build upon the lessons learned from our clinical community linkage project and be able to expand that, because our program is currently winding down. So it gave a little bit more attention and funding and focus on continuing what they could do and building in some sustainability. Increase the capacity for screening events to identify at-risk individuals, support more collaboration and partnerships, which is what has been so successful in our program, and then to be able to share strategies in a learning collaborative model. Here's some of our metrics. So number of people screened, what tools were used, what was their risk level, how many were referred back to their PCP, how many were referred to interventions, and then how many enrolled and completed. So these are each partnership with each of the metrics. So I'll just highlight here our results in terms of the total. So 8 events were held, 213 patients were screened. Individuals at high risk 52, moderate 85, individuals at low risk 76, referred to their PCP, referred to Matter Balance 165, referred to Tai Chi, referred to a home visit. And then in terms of, this is highlighted in obnoxious yellow here just to remind everyone that this is in progress. So these people were referred and they're getting enrolled, and they're working through completing some of these programs. So most of our data is not up to date as this just ended. We just collected data on this recently, but just to give you a sense, 71 had enrolled in Matter Balance, 30 Tai Chi, and then our completion numbers are low because people are still working through these programs. But we're excited that over 200 patients were reached in a very short time frame and are referred to these programs that will impact their falls risk. So just briefly, lessons learned. As we said, primary care does not universally do screening for falls risk, so there's huge opportunities there. Many evidence-based interventions exist but limited reach. Community screenings are effective but need to be part of a broader comprehensive systems approach. And incentives, our partners learned the incentives and the toolkit for training staff were really effective. And that our partnerships have built significant capacity that can be leveraged and built upon. There's significant gaps. As we all know, engaging patients and providers can be challenging. Linkage, there's not a comprehensive approach to linkage or reimbursement for this, and many patients get lost between the two, clinical and community. We need a comprehensive systems approach for falls prevention and sustainable funding mechanisms for reimbursement and reimbursement for screening and programs to make these accessible to all clients. Recommendations are similar to addressing the gaps I just mentioned. Incentivize PCPs to do this screening. Champions are very effective. Reimbursement and billing, coding advice, suggestions, guidance could really be useful. Again, we need sustainable funding for these evidence-based programs. Investment in clinical community linkages, integrating falls prevention into chronic disease. Considering, I guess it's more considering falls prevention as a chronic disease and bringing it to that level of attention nationally so that these programs can get funded and we can decrease this burden. And promoting these CDC tools, you know, they're amazing, and we don't need to be reinventing the wheel. One recommendation here is that the study tools be translated and available in different languages. One of our partnerships did that translation themselves into Chinese and was interested in having them available in different languages. I want to acknowledge our partnerships that I mentioned. They've done amazing work, all of them. And then a thank you to ASTHO again. Asti, Talia, and Erin have been wonderful supporting us through this program. And here's our contact information for me and the team members here in injury prevention if people have questions or follow-up. And here's a picture from our last in-person meeting with the teams from Vermont and Massachusetts and ASTHO.
Thanks so much, Laura. Really appreciate your presentation. And we've had a few questions come in. So while the state presentations are fresh in our minds and before we transition to our discussion with the panelists, I just want to take a few minutes to touch on some of those questions that have come in. So Chrissy and Laura, get ready. We had a question about, so it came in during the Vermont presentation, asking, can you do a case control analysis and look at outcome of falls versus no falls, and for exposure, received packet versus didn't receive packet, and then see if there was a significant association or not? Chrissy, are you able to respond to that?
I am. That's an excellent question, and we would love to get there. That is something that is part of the plan, depending on where this project goes from here. Like I said, we might be taking it hospital-wide, and this would be an excellent opportunity to do a case control analysis like Mary was talking about. At that point, it is beyond my expertise to do this type of study, so we would need to bring in our Quality Institute. They are already aware of this pilot project, and they're sort of like standing by in case we need them to do a more significant study than what we are doing for our pilot project. So that is a big hope that we are able to do a better analysis of the outcomes with people who have received the packet versus those who have not received not the packets, but the booklet. So that is something that we would love to get to in the future, and we're just seeing what direction we're going in with the hospital-wide initiative. But that is an excellent question, and we hope to be able to do that.
Thanks, Chrissy. We had another question asking what was the MOB intervention on the slide with the Tai Chi and home visits. Can you talk a little bit about that?
I believe that is for Massachusetts.
Yeah, that's for me. MOB is Matter of Balance, which is a program, an evidence-based program to reduce the fear of falling. So it focuses mainly on cognitive issues around the fear of falling and some strength, exercises around reducing the fear of falling. So it was one of the evidence-based interventions that we offered through our project, and it was the most successful in terms of falls intervention. Thousands of patients completed it. There's also a strong foundation built here in Massachusetts, and lots of our community-based organizations have been offering it in the past prior to our project coming on. So it has it's used here. People are familiar with it. What we were able to do was pay, basically our funding was covering these trainings, so it was free to participants, and we got a lot broader reach for compared to who would generally sort of walk into their senior center and sign up. We were able to reach a different population. But I'm happy to send you, if you Google Matter of Balance, you'll find information about it. It's a great program.
Awesome. Thank you. And as well for you, Laura, how did you train the primary care doctors? Was it part of a continuing medical education, a different approach? And are they paid for this screening? There's interest in hearing more about how the reimbursement for screening works.
Yeah, so this is a huge issue and challenge. So we had a consultant a subject matter expert go out and offer these trainings to our participating clinical sites. And we offered it to physicians as well as the primary care teams in general, so medical MAs, PAs, anyone, CHWs, to train them on what the screening and the assessment pieces are. And we had varying levels of buy-in, varying levels of success, but over 250 staff members were trained. We did offer CMEs. We were able to do that, so that helped. We offered food. The tricks to get this done. It's very challenging for primary care to do any more than they already have on their plates in these short visits. Billing and reimbursement was another big challenge. So there are ways to get reimbursed for this through the Welcome to Medicare visit, but the billing and coding issues are different for community health centers than primary care sites. So we actually recommended that as a topic for ASTHO to potentially take on, because I think there's more that can be learned. Some of our sites found creative ways of billing and coding for this. Others struggled. You can bill for a nurse visit, for example, if they're doing the screening. Some of our clinics set up falls clinics specifically to spend a full hour doing a comprehensive screening and assessment. So there's different approaches. There's no silver bullet. There's no easy way to do this. I think that's another area potential for the future, is figuring out how to really embed this in the work of primary care in a sustainable way.
Great. Thanks so much, Laura. We will transition now to the discussion with the panelists, but I see someone asked if slides will be available. We'll confirm with the presenters if sharing slides is okay with them, and we'll get back to the participants in today's call. But now we'll transition again to the discussion with our panelists to hear their remarks and feedback for the Vermont and Massachusetts teams. So I'll give you a bit of a bio on both, and then we'll hear from them. So we first are welcoming Brenda Iliff from the Hazelden Betty Ford Foundation. She has more than 20 years experience in the field of addiction as a clinician and an administrator. She has a BA in gerontology and worked in that field with older adults before her work in addiction. She has an MA in counseling from Regent University in Virginia and has become a national expert in accidental addictions and misuse of prescriptions. She's developed programming specific for boomers and older adults on chemical misuse, abuse, and addiction, and is the author of A Woman's Guide to Recovery, as well as many other articles on addiction and recovery concerns. Our other presenter is Dr. Gwen Bergen, a behavioral scientist at the CDC Injury Center on older adult falls. Her work is in the area of falls and older adult mobility. Her specific interests in older adult falls include study implementation and evaluation and understanding older adult attitudes towards falls prevention. She received her PhD in Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health and her MPH in Social and Behavioral Sciences from the Emory University Rollins School of Public Health. So I will turn it over to Brenda to get us started for a few minutes of remarks, and then pass it over to Gwen. Brenda, are you with us? You may be on mute.
And it looks like Brenda temporarily disconnected.
All right. Thank you, operator. Appreciate that. While we work to reconnect with her, we'll turn it over to Gwen.
Okay, thank you for asking me to comment. First of all, I'd like to make some comments on Chrissy's presentation from the University of Vermont. I just wanted to point out the strengths of the program in Vermont, and first that it was based on data. They used data to define where their largest problem was. Second, convening a working group to address the problem, pulled in people from various disciplines to work on this together. They developed focused material for older adults. And I really like it that they had a pilot unit where they tested this before expanding it to all the units. Finally, it's really great that you evaluated this so that you can see what's coming of your intervention. So I did have some questions about the program. I was interested in hearing what were the specific suggestions that you included in the materials for the patients.
Hi, yes. So are you speaking of the booklet?
Yes.
Okay. Yeah, so in the booklet, the cover page had suggestions to contact your primary care physician, for follow-up information, and if you had any questions or concerns. Another point was that we tried to hit people in different phases of their life, if you will. So, those who go to a website, we referred them to the Falls Free Vermont website. For those who prefer to call someone or, have a hotline number, we referred them to the Vermont Older Adults Hotline. And that's just a referral system to various community activities. So when someone calls, whoever the receiver is of that phone call knows what zip code they're in, and then we'll refer them to the appropriate community resources. And then we told them to go to the CDC website as well, talk to family members, and also follow up with their primary care physician if have questions or concerns about their home safety. We also talked about the Vermont or the UVM Falls Clinic, and that Falls Clinic will do a complete evaluation of the person, what medications they're using, are they using a walker, all the way down to what shoes they're wearing, and then they also do an in-home assessment. So we try to to touch all of those different points. And then beyond that cover page, it is information that we took from the CDC's study website and, things to look for. Have you answered yes to any of the questions on this checklist? If so, then, we recommend that you follow up with your primary care physician. So it also, brought up what their home looks like. Do you need assistance, like walking up your stairs? How's the lighting in your home? Do you have tripping hazards? Things of that sort from the CDC's website. So it's about a 4-page booklet, but we try to get as much information without making it overwhelming for people.
Okay, thank you, and thank you for using the CDC's resources.
Yeah.
I'll move on to Massachusetts and Laura's presentation. Again, there were a lot of really great things about this presentation. Again, it was data-driven. Another thing that really impressed me was the use of the electronic medical record to communicate with the community organizations without a person having to get involved with it. As far as the ASTHO specific intervention, again, the fact that it was evaluated and that you showed such fantastic results as far as getting older adults to actually become enrolled in the programs, that is something that all of our implementations struggle with a little bit. And I was just wondering, what methods are used to motivate patients to follow through and actually enroll in the different interventions?
Hi, sure. Yes, thank you. That was a huge focus of our project. I would say the biggest focus of our project. It was engaging patients. So Because we had significant funding, most of our sites hired CHWs. We actually had 72 CHWs hired for this project and trained. They did a comprehensive CHW 80-hour training. So we're very proud that we've sort of helped move that workforce forward, and many of them are now getting employed through ACOs here. So I would say it's sort of the first answer, the easy answer is CHWs really were what we were able to use as a very effective strategy for mobilizing patients. So they were trained in motivational interviewing. They called patients. They followed up with patients. If they didn't come to the second class, they called them. We had them use some of these strategies that there's research, lots have been published on strategies for getting patients engaged and having a champion, so a patient champion who had completed the program call them back. We provided transportation was covered. In some cases, babysitting was covered. A lot of intensive resources were spent working with patients. We had bilingual, multilingual CHWs who were able to communicate with patients in their language. We translated materials. We had letters going out saying your provider recommends this, we recommend this, this is evidence-based, how can we get you there? If it's not a good time this time, can we call you back for the next round of classes? Lots of intensive work was done on that. I think another piece that I want people to hear is that the linkage with primary care, so getting the primary care on board with recommending it, in a meaningful way, talking to the patient, sitting down with them. They had handouts about the interventions, pictures of the CHWs, pictures of the leaders at the group. They tabled, some of the CBOs tabled in the primary care site saying, are you interested in these programs? Do you want to hear about our programs? These are available to you. Your provider thinks it's important. We want to help you stay independent. So lots of effort went into making those completion rates as high as they are.
Okay, thank you. Both those were really impressive presentations. And now I want to turn it over to Brenda so she can give her commentary.
Thank you so much. And again, I would reiterate they were both very impressive. I love, congratulations on the work that you've been doing and how you've involved the community. I'm thrilled with learning some resources that are more natural. Some sound like a little cognitive behavioral therapy resources. So one of my questions would be how much screening was done around chemicals in all of these falls, including were they seizure related from withdrawal. So I don't expect an answer to that, but just in the future as we move on, might be helpful to do some screening there. Mm-hmm. Do you want me to start the presentation now, or?
Brenda, yeah, please go ahead. You're welcome to
Okay, I'm sorry. I thought I was just responding. Okay, well, it all started so innocently. Just like many other people, 50 plus, Betty Ford found herself in a situation she never thought she'd be in, a person with addiction. But just like many others, she moved from the stigma of addiction to a life filled with purpose and meaning. Addiction in the population that we're talking about is estimated as high as 17%. While today's webinar clearly is focused on falls, for many older adults, the substances may be behind these falls. It can be the opioids, which are the painkillers, the benzodiazepines, which tend to be more the anxiety or the sleeping pills you hear a lot about, or alcohol, or a combination of any of them. Addiction's estimated as high as 17% in this population. That's significantly higher than the general population, which is about 10%. While as a nation we're in the midst of an opioid epidemic, it's important to remember that for most folks it's really about a trifecta: opioids, benzos, and alcohol. Yet for this population, opioid misuse has almost doubled in the past decade, and the hospitalization rate has quintupled. 42% of the overdoses in our country are people 45 and 50. Almost half of our overdoses are people over 45 years old. And yet the media would make us think it's all younger folks. Substance use, any mood-altering substance, can increase the likelihood of risk of falls. It doesn't have to be all the way to addiction. It can be simply using mood-altering chemicals. There's greater risk of substance use for people who are 50 plus. These are people who are part of the sex, drugs, rock and roll, and they aren't afraid to go back to it. Polypharmacy also adds an increased risk. Polypharmacy is using 5 or more prescriptions or supplements. We need to ask about the supplements too. You may all know that, yet how many of the clients you work with are on less than 5 prescriptions? Besides the basic risk factors can also be health concerns, losses, lots of losses as we age, socioeconomic status, race, and even gender can increase risk factors. Those with chronic disease also have an increased risk factor. The resources and the wisdom from the past give way to higher recovery rates. People have a lifetime of experience they can draw on. They follow the rules also. They tend to be more disciplined about recovery. Generally, they're more medication compliant, and they relish finding, again, a life of purpose and meaning. The resources and wisdom from the past paved the way for an increased health experience, including decreased falls as we get people off the chemicals. Their motivation is strong, and many times the motivation comes from valuing their health or wanting to stay independent. Other times, though, it might come from just wanting to see the grandchildren. Exposure to benzos and opioids can make anyone, regardless of their age, at risk for abuse of those drugs. They're both highly addictive, and they're really meant for short-term use. For people 50 plus, though, other exposures, as you know, can be the excessive sedation, the falls, and the cognitive impairment. Risk also can be rebound pain from getting off the drugs, depression, fear of getting off the drugs, slowing down an already slow aging metabolism, and suicidality. Lots of risk factors. The years of pain and anxiety add up. Who doesn't want some comfort? The health stakes and losses get higher. Who doesn't want some relief? Respiration and cognitive abilities can get slower. And, to be honest, it takes a lot longer to get off the chemicals. So we're going to get you involved now. In a Medicare study of people 55 and older, what drug increased 52% from 2007 to 2012? Take a look at that list, and it looks like we're having a little problem with the survey, but the answer is not Cialis, actually, folks. It's hydrocodone, although many of our guys probably wish it is the Cialis, but hydrocodone increased significantly, and not only how many prescriptions are out there, but also how long the prescriptions are used. You can see from this slide that both the narcotics and
Brenda, are you still there? It seems you may have disconnected.
She did.
All right. Sorry about that for the participants, for hanging with us with the technical difficulties. It seems that Brenda's line may have disconnected. So we will try to get her back on, but in the meantime, I will move us forward to Gwen's slides so that, Gwen, you can pick up and take it away.
Okay, thank you for inviting me to okay, are you going back? I think Brenda may be back on.
Brenda. Brenda, are you back on the line? All right. We will try to get in touch with Brenda, but in the meantime, Gwen, if you can just verbally get us started, and we'll try to reconnect with Brenda.
Okay, thanks for inviting me to speak today. I'm going to talk about the medical cost of older adult falls. I think you all know the background. I've seen these numbers in some of the other presentations. But in 2014, over 1 in 4 older adults reported a fall. And this resulted in 7 million falls that year that required medical treatment or restricted activity for at least a day, along with 27,000 older adults. We do have some updated data for later years, and it's looking pretty consistent. The numbers are going up a little, but obviously older adult falls impose a large burden on our medical system. Our first question is, what is the medical cost of fatal falls? And it's an estimated $754 million in the year 2015. It's fairly straightforward to get a medical cost of fatal falls. Our vital statistics system gives us a very good record of deaths from falls, and CDC's web-based injury statistics query and reporting gives estimates of the cost of injury by age and by external cause. So you can go in there and get a good cost for falls, and this is a pretty standard estimate. It gets a little harder when we look at the medical cost of non-fatal falls. Our most recent estimate for 2015 was about $31 billion, but that's for Medicare only. It's based on emergency department visits, hospitalizations, and outpatient visits, so it may miss costs that aren't associated with a specific medical visit, like if the older adult has to go to physical therapy as a result for the fall, that may not always get coded correctly, so that we pick up the cost of that. And the same thing for a lot of prescriptions. This is also a labor-intensive estimate involving multiple databases. So our goal or objective for our recent study on the cost of falls was to develop a method to estimate non-fatal medical costs for older adult falls using a method that's comprehensive in that it includes all medical treatment and all payers, not just Medicare. It minimizes the number of data sets used, and it will be easily updatable year after year so that we can start establishing a trend of what older adult falls cost us in medical terms. For the study, we started with the Medicare Current Beneficiaries Study, which surveys a sample of Medicare beneficiaries. And one of the questions is whether or not the subject has fallen in the past year. Along with the questions, it includes all medical payments for that person by payer and service type. So we used that survey and developed a couple of regression models that controlled for falls and any other characteristic of the person that might increase or relate to how much money is spent on them on health each year. And this included things like gender and health conditions, for example, depression, which is very expensive. So we ran a regression and we saw what part of expenses falls contributed to. We got the actual total expenses if we included falls and all these other variables. Then we also ran the equation with falls set to 0 to give us a hypothetical estimate of what our medical costs would be if there were no falls. And we used those numbers to get an attributable fraction for falls, which is a fraction of how much of medical expenses are due to that person experiencing a fall. We were able to get that by payer, by Medicare, Medicaid, and private/out-of-pocket. We also were able to get fractions for each of these service types. So then we took the National Health Expenditure Accounts, which is produced by CMS, and it's the official measure of total health care spending in the United States. We took our attributable fractions and applied it to expenditures for those 65 years and older to get our estimates by payer and service type. And our results were that the medical cost of non-fatal older adult falls is $49.5 billion annually. That was the estimate for 2015. Medicare pays $29 billion. private out-of-pocket $12 billion, and Medicaid pays $9 billion. When we looked at it by service type, the other service type was the largest amount, and that includes things like home health care, nursing care facilities, continuing care, durable medical equipment, a lot of things that might last longer than the acute visit in the hospital or the visit to the physician. We found hospitals were responsible for $13 billion and the physician and other provider for $11 billion. They were the major sources of expense. So to summarize, we found that older adult falls impose a large economic burden at $50 billion for fatal and non-fatal falls, and 3/4 of those costs are paid by government-funded programs. This is a problem because, as we all know, the older adult population is growing from 46 million in 2014 to an estimated 74 million people in 2030. If we don't do anything to prevent falls in the older adults and they stay at the same percentages they are now, we can expect that 20 million falls and 7 million fall injuries in 2014 to be 12 million injuries and 49 million falls by 2030. Also, based on a recent CDC publication, we see the falls death rates have increased for older adults over the past 10 years at an average 3% increase per year. But as we've seen in the two presentations today, falls are preventable, and the CDC recommends using the STEADY initiative or a process like it, where you have primary care providers and actually other community and health professionals identify patients at risk for a fall by screening them with questions. For the patients who are at risk, you then assess them to identify modifiable risk factors and follow up on those risk factors by using evidence-based clinical and community strategies to address and modify and change those risk factors to prevent falls and reduce the medical cost. You'll be able to get these slides. This is the article, Medical Cost of Fatal and Non-Fatal Falls, that I just presented on, and it's been released. And then also a few weeks ago, we released this article that uses the national cost work we've done and another method to provide assistance to the states in estimating what the economic burden of older adult falls in their state is, and it has some state-specific costs. So thank you for having me speak. And I'll turn it back over to Brenda.
Hi, everybody. Sorry, I keep getting kicked off the line, but I'm going to ask somebody to move my slides for me because I'm not quite back into that, but we're on the slide called Medication Generation. We are a medication generation. We're focused on our pills, and we have all kinds of reasons of why we need our pills. Common misconceptions. Let's move to that slide. I think I can move us now. Thank you very much. Common misconceptions and justifications we hear are, well, it's over the counter. If it's over the counter, it must be harmless, or I'm taking it as prescribed, or, you know what, I can't afford it anymore, but I might as well drink. It has the same effect. And, of course, the most common one we hear is, my doctor prescribed it. It's important to talk with people about all medications, including the supplements. Ask people to bring it all in. Do a brown bag review. It can be a mess. You're going to have lots of pill bottles in your office. But it's amazing what you'll find when you start looking. You also may want to involve the pharmacist. So now it's time to get you involved again, and I hope I don't lose you. But we have a survey, and you can just click on the one that you think is the correct answer. People at 50 plus are more at risk for addiction because why? What do you think? Do you think it's pain concerns, multiple diseases, sleep problems, metabolism changes, or all of the above? Let's see what you're saying. All of the above. That's correct. They're at huge risk because of all of the above. I want you to take a look at this next screen. It lists a lot of different medical concerns, which you're probably very aware of. Of all these concerns, which ones absolutely could not be tied to substance use? And then my second question is, of all these possible substance use concerns, which ones of them are not medical concerns? Can you see how tricky it can get when you're trying to screen out things for folks? It all started so innocently. Many of the folks we're talking about really are coming upon this accidentally. As we age, our metabolism slows considerably. Our body fat increases, our water content decreases, everything slows down. That liver, those kidneys, they don't get rid of the toxins as well. The body becomes a greater risk for addiction, even with less of the chemicals than we put in previously. Yes, a person may say they're drinking less, and they actually are, but their body can no longer process it like it used to. And then we add aging concerns. The yellowing of the lenses, the vision changes. We can't see the difference between the blue and the green pill. We're not quite sure we heard the right thing about our meds. That particular drug increases my confusion. It's really the perfect storm. So we know the reason people move into it, but what do we do about it? I commend you for asking for someone to talk about substance use on this seminar. It's important that we bring that into the conversation as we're addressing falls with people, because you all know the vicious cycle. Was it the opioids that were used for the pain that caused the fall, or was it the fall that caused the pain that got people on the opioids or the benzos, or was it the depression that got them on the benzos? But it's a vicious cycle, and we need to intervene in any way we can to get people out of that cycle. Thrilled to hear some of the resources that are being used today. Would really direct your attention to the CDC's guideline for prescribing the opiates. Take a look at them. They've got some fabulous pieces there. Do we use them? Are there other non-opioid treatments? You learned about some today that help people. If you do need to use them, start low and go slow, and then avoid putting them with the benzos. Those two together can be really concerning. They also have some guidelines. Do I initiate or do I continue? And then if I do decide to initiate, how do I select them? And also, how do I discontinue? It's important for folks to know that getting off those chemicals, the benzos and the opioids, there's a significant discontinuation syndrome. We call it withdrawal, but sometimes using the term discontinuation can take a little bit of the stigma out of it for folks. And what do we do when people cross the line? How do we talk to people about it? Well, if you need to talk with someone, be respectful. No one wants to cross that line. Stay away from labels. Don't be talking alcoholic, drug addict. Try to tie it back to their health, to their independence, as these two can be highly motivating factors. Address some of the myths. You're being educated today on some of the myths. But one of the big myths is that opioids are effective for long-term chronic pain. They are not. Now, clearly the guidelines from the CDC put palliative care outside those guidelines. So we're not talking about palliative care. We're talking about chronic pain and acute pain. The risk is significant, and detox needs to be obviously medically monitored. There is some helpful medications out there that help people through the process that are not addictive, including the naltrexone. And then how do we help folks with some screening? There's lots of different screening tools out there. An easy one is the Cage. Have you tried to cut down or control your use? Are other people annoyed by this? Do you feel guilty about it? How are you feeling about it? And then are you finding yourself using earlier and earlier? I know we have a lot that we can cover in this, but I do want to thank you again for inviting the conversation around substance use, just basic use, misuse, and abuse that can be a problem for folks and increase their fall risk. Thank you so much.
Thank you so much, Brenda, and I'm really glad you were able to come back and connect with us after some of those technical difficulties. Sometimes those are out of our hands, but thank you again for sticking with us, and to both you and Gwen for your expert presentations. It's really nice to be able to complement the state presentations with some other perspectives and just other work going on in the field that intersects or is going on at a national level. So again, thank you. We have some time for Q&A, so please feel free to type in any additional questions you have in the chat box. But to get us started, I want to ask the Vermont and Massachusetts teams if you can each share your reaction to the presentations from Brenda and Gwen, and any ways that you see using this information to inform your work.
Hi, this is Chrissy from Vermont, and it was really wonderful to see the slides from both Brenda and Gwen. To address Brenda's slides, it is, all states are working on addressing the opiate crisis, and Vermont is no stranger to that. But it is interesting, there's not a lot of work in our state currently to address the connection between falls and opioids. So that is something that I'll work with our community partners and the Department of Health to help raise awareness of that. Part of what we wanted to bring in to our stakeholder group were primary care physicians, but as Massachusetts know, that's very hard because their time is so limited. But we definitely wanted to bring in pharmacists into the mix to talk about medications and how they affect people's balance. And so that is something that I look forward to making those connections. And then, Gwen's comments on just the projections of, if things stay the same, what are we going to look like in 2030? And those numbers are pretty scary. And Vermont has a pretty significant aging population. So, those are things that we need to start preparing for in the future, and really ramping up our work and really focusing on interventions like what Massachusetts is doing, with Matter of Balance and Tai Chi, and then also figuring out a way to make these screenings billable. So those are all things that I look forward to working on.
Thanks, Chrissy. And Laura, any reactions or comments you have after hearing Brenda and Gwen's presentations?
Yes, thank you. They were both excellent. I was excited to hear Gwen. Thank you. I love the overview of sort of the burden piece, and I was wishing you had gone before me to highlight, how significant of a problem this is nationally. So I love the CDC. As I've said, the CDC study tools and these infographics I think are really easy for people to digest. So I would urge people to use those, get those out there, help communicate this burden. And around the cost piece, I'm eager to read these papers. We've struggled with how to analyze the cost impact of falls as well. It was something that our evaluator struggled with. How do you put a number on a prevented fall, the injuries, the sequelae, all of the things that you mentioned. So thank you for that. I'm proud that the CDC has focused so much attention on this, and hope that translates down to states having more resources to be able to look at falls and help implement. We have so many lessons learned. And EMR, someone had mentioned before, EMR changes, that's a strategy that's worked, that we've already seen as an effective way to really implement this through PCPs, is getting the EMR changes made and rolled out. So thank you, Gwen, your presentation was great, data-driven, focused on numbers and costs and burden, and I think it's all something we can use. All of that are resources that we can use and disseminate broader. And then Brenda, we thought a lot about how to integrate screening the CAGE in for older adult falls for falls. So one of the conditions that our program focused on that wasn't one of the 4 priority conditions, we had optional conditions. One was substance use. And many of our sites that implemented that were curious about how they could sort of focus that screening on the older adult population and the intersection there. So we met with our bureau here on substance use multiple times and took the CAGE out and tried to talk to sites about, targeting their over 65, using the CAGE, and then that's a, win-win for fall. So definitely on board with everything that you said, huge priority. We struggled. I think we had 2 sites that were able to use that CAGE with their older adult population to try to look more closely at medications specifically. So I think there's lots of opportunities there to do more, but thank you. It's really educational to hear about the data around how significant of a problem opioid use is with older adults. So thank you both.
Excellent. Thanks so much, Laura, for your comments, and really glad to hear the back and forth discussion between the panelists and the state presenters. Again, thank you all for your time and your effort and willingness to share your experience with us and the audience. So we are nearing the end of our time today, and before we go, I want to point out some resources on healthy aging that are available through ASTHO. We're delighted to be a partner to the folks on the phone in falls prevention. And so the first item you'll see here is an issue brief with an overview of the Vermont Falls Prevention Quality Improvement Learning Collaborative, building on some of the examples you heard earlier today from the Vermont presentation, some of the work that came before is highlighted in this issue brief, so you can download it from our website. And then additionally, we have a special Healthy Aging website page on our organizational website. It is to be revamped this summer, so stay tuned, and you can find a number of resources here. We did record today's webinar and we'll be posting it on our website and sharing that with you all, so stay tuned for that. But that brings us to the end of our call. So thank you all again for your participation in today's ASTHOConnect webinar on older adult falls prevention. If you have questions, please feel free to contact the ASTHO team. You will be directed to a survey following the webinar, and please take a moment to fill it out. We really value your input to help us create useful learning opportunities for the future. Thanks again to our speakers, our panelists, and to all who participated. Have a wonderful rest of your day.
Thank you.